Dear colleagues, this is phacoemulsification of a cataract with mid-dilated pupil and a very shallow anterior chamber. Prophylactic peripheral iridotomy with ear glazer has been done for this patient. I've taken out this case for surgery. Let us watch the surgical steps. By this time, the main incision and one side put have been made. Now I want to use adrenaline to see if the pupil dilates little more. So here goes the adrenaline underneath this air bubble. Here it is. So the adrenaline is injected into the anterior chamber. The adrenaline should go behind the iris for nice dilatation. Now this is trypan blue dye. I want to stain the anterior capsule also to make rhexis easier. Now I can see that the pupil has dilated little more, and with injection of viscoelastic substance it has dilated little further, and this is adequate size pupil for doing capsulorhexis. One more side put here at around 8 o'clock, and now I incise the anterior capsule with this bent needle, and now I take a ureter forceps, hold this capsular tag, go anticlockwise, and now see what happens. The pupil has started to become small. However, the rhexis has been adequate. I have touched the iris at around 5 o'clock, and the pupil has started becoming smaller. Now hydrodissection is being done. As I do hydrodissection, I touch the iris, and as I touch the iris, the pupil becomes more small. Now I rotate the nucleus, depress the nucleus, and I can see that the pupil is becoming smaller, and I'm afraid that I will not be able to do surgery without using some pupil expansion device. So I've decided to use B-HEX pupil expansion device. I'm using the forceps, 23 gauge forceps, takes the device inside the antechamber, and one flange is tucked under the iris. The flange that is at around 5 o'clock has been tucked under the iris. And now I've taken the forceps. Now the flange that is between 9 to 11 is being tucked. Now the problem is I cannot see the other flange. There is arcus, dense wide arcus, and I can't see it. With 23 gauge forceps, I can't see where the... So to improve visibility, what I do is inject some visco over the corneal epithelium after washing the epithelium. Here it is. And this improves visibility to some extent. Now I'm using a Sinskey hook to pull the haptic, yes, to pull the flange. And with Sinskey hook, it is not, the flange cannot be controlled very nicely, but I could pull it, and now I can use the forceps, again 23 gauge forceps, to place it properly. So here goes the forceps again. I hold the flange and tuck it properly. That's it. Now I have got a pupil of about 5.5 millimeter size, and this pupil will not become small while I will manage the nucleus. That is very important. And now is the time to enter into the eye with the tip of the phaco handpiece. I am using Oatley Cataracts 3 phaco machine. The easy tip is introduced into the anterior chamber. This device doesn't cause any hindrance at any step of surgery. Very thin, versatile pupil expansion device. Hexagonal pupil and more working space. The tip is buried into the substance of the nucleus and the nucleus is chopped. This is a hard nucleus. Nucleus sclerosis is grade 4 or grade 4 plus, and I am doing this what I call submarine chop. The tip is totally buried into the substance of the nucleus. It goes for some, advances through the nucleus for some distance, and then it is chopped. That's it. That's it. The nucleus has been chopped into several fragments. Now each fragment is emulsified and taken out. See, the device has kept the pupil so nicely dilated that the surgery is very comfortable now. If I didn't use the device by this time, the pupil would have been very small and it would have been very difficult to manage the case. The nucleus is managed. Now this epinucleus at 5 o'clock, it is removed. And now little bit of viscoelastic substance is injected into the anterior chamber. In this case, I am going to use bimanual irrigation aspiration to clean the cortical matter. Once you apply B-HEX, you can forget it. And after completing this surgery, you can recall that there is some pupil expansion device. Now this is the cortex at 6 o'clock. Now a little bit of polishing of the posterior capsule is done by the jet of fluid. Viscoelastic substance is injected into the antechamber. Now a foldable intraocular lens is implanted in the capsular bag. This is a hydrophilic acrylic foldable intraocular lens. The lens is gently introduced into the antechamber. Now with the help of a Sinskey hook, the trailing haptic is dialed into the capsular bag. Here it is. Now the lens is in the capsular bag. It is dialed. Now see how the B-HEX expansion device is removed. It is held. All the flanges are untucked. The device is pushed towards 6 o'clock. Now the flange just in front of the main incision is held with the forceps, and very gently it is pulled out. That's it. And now viscoelastic substance is removed. This is a Simcoe cannula. See, the pupil has become so small by this time. So there is hardly any sphincter damage. Pupil is round and it has become small. If the pupil becomes small, it means the sphincter damage is not there. So actually, if it is not a rigid pupil, if the pupil becomes small because of floppiness of the iris, then sphincter damage is less. And with B-HEX pupil expansion device, probably the sphincter damage is least. You can see the iris tends to come out through the main incision, through the side put, and this indicates floppiness of the iris. So I have used the ring at the right time. I have followed up this case. The patient is doing very well. This is moxifloxacin. Now the side ports are hydrated to make these wounds waterproof. After hydrating the side port, a final lavage of the antechamber is done. This is a view under higher magnification to see if anything is there, any particulate matter, anything. That's it. The case is done. Hope this video will help you in developing your surgical skills. To uplift young surgeons is my only aim. Thank you very much.